Good evening, all the aspirants. Good evening, sir.
Hi, good evening, everyone. I'm Dr. Aklesh. Welcome back. Yesterday, we could do half of our presentation, but today we will try to complete the table viva questions. And I hope you all will be very, very interactive so that the discussion becomes more and more enjoyable. Let me just see my PPT. So without any delay, we will take some questions. You can also add whatever you feel like adding to the important points. Okay. So this was one of the questions which was asked. I think some of you must have gone through these questions in the exam. But for the others, let us discuss. So such questions may be asked in your exam, Viva, huh? What are the components of high quality CPR? So this is just to brief ourselves, we need to scratch. Sometimes we feel like we know everything about CPR, but at the end, when such questions are asked, we fumble. These are very important aspects of the CPR management, and if you're not aware, so that doesn't give you a good impression as far as the examiner's perspective is concerned. So that's difficult. So whenever we think about high quality CPR, it has to be push hard, push fast. At least 100 compression should be given. Then we should emphasize on depth of compression should be at least 2 inches. We should allow the chest to recoil completely after each compression. Otherwise, if the chest is not recoiled completely, there will be ineffective ventilation. Or otherwise, there will also be some amount of autopsy that may be developed. And we have to avoid interruptions in the chest compression. The more the interruptions, the more the circulation which is compromised. And when the patient is on ventilator, we should avoid excessive ventilation. So these are important aspects. Okay. I hope you all understood. Let's go to the next question. So can somebody take this question? Stanny? Hi, Stanny.
Yeah, hi, sir. Yes, I can try. The nurse notes a marked difference between BP, recorded arterial line in one arm, and non-invasive pressure recorded from the other arm. What may be causing this difference? Well, aortic dissection, subclavian arteria stenosis. Yeah.
Sorry. Anything else?
Anything else?
The first is transducer should be in line.
Yes.
Second is
Yes.
artery line may be damp.
Yeah, damn arterial line. There may be
And
clot or kinking of the line. Okay.
non-invasive blood pressure cuff is loose or tight.
Mm. So
And after
basically,
that,
yeah, any other parameter?
aortic,
Basically,
then
non-invasive BP is based on oscillometric principle. In a low flow state, the blood pressure recorded may not be correct. So that's why you need arterial blood pressure monitoring. Okay, which is an invasive method for blood pressure monitoring. We place a cannula into the artery, and this is based on Whitstein's principle, I guess. Okay, there are resistances applied on the circuit, and then the change in the resistance is directly proportional to the change in the pressure. And then the pulsatility of the waveform is measured. Okay, when the arterial cannula is in the artery, the blood flows in a pulsatile manner. And then the diaphragm, the diaphragm, there is a mechanism which senses the flow of the waveform. Okay, how much is the height of waveform? Okay, and then these waveforms are, assessed on a continuous basis. Okay, and then the electrical connections that goes on to the monitor will analyze the waveforms, and it will calculate a graph, a plot. It will plot a graph, and the area under the curve will give you values like the blood pressure, systolic blood pressure, diastolic blood pressure, dichrotic march. So that's why the invasive arterial blood pressure monitoring is more uh, reliable compared to non-invasive blood pressure. But yes, there are also factors which are called as dampening factors that also has to be taken into consideration. The system may be over damped, so that's why the blood pressure may be measured low, but the mean arterial pressure is going to be same, whether it is over damped or under damped. Okay, and in under damped situation, you will have the exaggerated systolic peak. So that is how you differentiate. Even arterial blood pressure monitoring is also going to be erroneous if it is not interpreted well. But make sure that whether the system is overdamped, underdamped, the mean arterial pressure is not going to change. So that's why arterial blood pressure monitoring is more reliable compared to non-invasive blood pressure. So as somebody said, yeah, device factors are also very important. If the cuff is in non-invasive blood pressure monitoring, the cuff size is very important. It should encircle at least 2/3 of the arm size should be selected. Okay, if the cuff of the size of the cuff is too big or too small, you're likely to get the abnormal values. And as I already said, this is based on oscillometric principle. And if the patient has arrhythmias, these measurements may be erroneously wrong. And if the patient moves, then also these oscillometric methods may give you wrong readings. So that's why you need invasive blood pressure monitoring, where you use transducer and you have to zero the transducer correctly. Okay. If the blood, even in arterial invasive blood pressure monitoring, if the artery is under spasm, or if the patient has peripheral vascular disease, okay, the subclavian artery stenosis or aortic pathology like aortic aneurysm, you may have erroneously wrong values. Okay, so this is another question. I hope you understood.
Sir,
Anything you would like to add?
sir,
Yeah.
sir, in first question, there is a depth is 2 inches, but latest guideline is 2 to 4 inches depth and rate is 100 to 120.
Pardon, which question?
The first question.
First question.
Yes, sir.
Hmm.
The push
Yeah,
is
100 to
push
120.
at least 100. That is 100
Yeah,
to
100 to
120, and
120. Yeah.
compression depth is 2 to 2.4 inches.
Yeah. Thank you very much. Absolutely right. Absolutely right. Hmm?
Okay.
Yeah. Thanks for the correction, dear. Okay. So this is another question that I would like to take, and you can also answer. A large bore catheter for renal replacement therapy has been accidentally inserted into the carotid artery of a man with multi-organ failure. And this patient also had coagulopathy due to systemic sepsis. The location of the catheter was only discovered after it had been sutured in place. List the potential complications and outline how you are going to deal with this problem. I would be happy if the participants take this question voluntarily. Can I select Fatima? How would you take this question? Fatima is our host. Hassan Bara, would you like to take this question? Consider it as a practice session also. Okay, but if you are incorrect, I would like to add further.
Yeah, a large bore catheter for renal replacement therapy has been accidentally inserted into the carotid artery of a man with a multiple organ failure, including coagulopathy due to systemic sepsis. The location of the catheter was only discovered after it has been sutured in place. So in that case, we should not remove the catheter immediately. We need to keep it in place. We need to involve the thoracic surgeon. We need to call them, and we need to make sure that that the catheter should not be removed, because if we remove the catheter, the bleeding will be enormous, and we cannot control it. So it should be under in the theater and under thoracic surgeon care. Yeah.
Yes, absolutely, absolutely. Anything else? Anybody would like to add? So
Anticoagulation.
Ask the blood group being cross matching, we can anticipate bleeding, and Yeah, we need to secure other line if possible. Preferably or central.
Central venous catheter, you need to have a good IV access, meaning, right? You should have a good IV access, preferably a wide bore angiocath will be better here, because if the bleeding is torrential, even central line also would not help you to administer fluids or blood rapidly. So two wide bore cannulas also will be very important. Yes, for the vasopressor support for time being, central line may be preferred.